I'm going to go ahead and call the meeting to order. If you want to leave by 3, you have to start at 1.
Yeah, sure.
I'm Nick Kinley, and I'm going to chair this session and give Judy. Is this better now? Okay, thank you for the help. So I'm going to chair this session, and first, I guess the order of business is, Shane, if you would call the roll to establish a quorum, please.
Senator Kenley,
Aye.
Dr. Monroe,
Aye.
Dr. Box,
Aye.
Dr. Maxey,
She's coming.
Mr. Ellison,
Here.
Mr. Tabor, Dr. Veal,
Aye.
Ms. Irwin,
Aye.
Ms. Waldron,
Here.
Dr. Halverson,
Here.
Dr. Kane,
Here.
Dr. Welch,
Here.
Commissioner Bardsley,
Present.
Mayor Courtney,
Here.
Commissioner Dawes,
Present.
Congresswoman Brooks.
Here.
We have a quorum.
Thank you, Shane. I'm going to briefly go over the agenda here and talk about what we're going to do today. We're going to hear from Commissioner Bardsley from Grant County and from Mayor Courtney from Madison and Kim Irwin, and then we're going to give them 5 minutes to make a presentation on comments about Indiana's public health system. And then we're going to have a major presentation from Pam Pontonas. And so if we could, when the first 3 speak, let's just move on into the presentation by Pam and let her talk. And then we're going to have an open discussion meeting about what she presents. And then any questions that you have regarding the earlier comments, let's take those at the same time. And I want to report that, first off, we've handed out the minutes. I wonder if we could have a motion to approve the minutes with a second and a vote.
Motion to accept.
Dr. Welsh, okay.
Second.
I've been moved and seconded that we approve the minutes as distributed. All in favor, say aye.
Aye.
Thank you. Dr. Box and I, behind the meeting minutes on your packet there is a list of the meetings that we have had. We call them our roadshow meetings, where we've met with different groups to try to get our message out to them, what we're doing and what the objective of the commission is and what we hope to achieve. And Dr. Box, so far, she and I have had 8 meetings on this since the last meeting. So I think I'm going to go to an hourly rate. This lump sum payment. By the way, some of you have been asking what your pay is. And so this is your first installment today. And for everybody who wants to, this is a piece of candy. And for Dr. Box, this is a Christmas tree ornament. I asked, Dr. Box has just done a terrific job of making a pretty concise but thorough and complete presentation in our Zoom meetings. And this is a copy of it. And we have been handing out copies to the members of whatever organization we're talking to. So I asked Shane to get all of you a copy of that. And the importance of, if you look at the list of who we're talking to there, really, this is in preparation for preparing a final report next summer, making recommendations to the governor, hopefully going to the legislature in 2023 and asking for an implementation of whatever we put together with regard to structure and funding and so forth. And so this is an early effort to get some transparency and some education out there with everybody. This is all hinges on, as I used to say, on any bill that I carried in the legislature. Success means that you had 26 votes in the Senate and 51 votes in the House. And so that's our ultimate objective. And so as you go back home, if you think there are other groups that we need to talk to, or if you think that there's something we need to do on this approach of how we're going to sell what is, in my opinion, a very necessary and change for governance here in the state of Indiana, why, let us know, and we just need to keep working on that side of the agenda. So with that, I'm going to call on Dr. Monroe for any comments that you may have. Judy?
Yeah, well, thank you. So first of all, thanks to all of you for the engagement throughout all the meetings so far. I've really found the discussions fantastic. I do want to give a big thanks to Dr. Box and Senator Kinley for these road shows. I mean, that is impressive how many they've already done and how many they plan to do. So that's really fantastic. The topic that we're going to be talking about today is critically important. And it's somebody said a little bit heady. It's it's a deep topic, but I want to do a shout out. Pam Pontonis, I had the privilege of working with when I was state health officer, starting in 2005 when I first met Pam, and she is an Indiana treasure. So I want to start with thanking Pam for the work and everybody with all the work that's gone into the presentations. And another big shout out to Mindy. She did a fabulous job on the first Lights Camera Action National Summit on the future of public health, and represented Indiana and the commission very well. There were a lot of questions, both in her panel, but then also in a breakout session where there's a lot of interest around the country, as I've mentioned before, about what Indiana's doing in the commission. So that was fantastic. The next National Lights Camera Action Future of Public Health Summit will be January 25th, and that will most likely feature Indiana again because it's on information technology and data modernization, which Indiana obviously has been a leader with Regan Streif and all that the state health department's been doing recently and so forth as well. So registration's open for that. So with that, I'll turn back to you.
Well, thank you. Congresswoman Brooks, any comments from your corner today?
The only thing I wanted to share with everyone is that I actually worked, and I'm a little surprised by this, Judy, with Pam Pontonis back in 2001 and 2002, because at that time I was the U.S. attorney when the anthrax attacks happened in the country. And so not only were we, working with local law enforcement to talk to them about preventing terrorism after 9/11, but we ended up doing a roadshow around the state with Pam Pontonis, taking her to visit with local law enforcement and other community members to talk about biodefense back then. And I know Dr. Kane, I worked with you here on that as well during that time. And truly, it is because in DC, when I started getting involved in biodefense, everyone would say, why do you care about this? Now, this was long before the pandemic. And I said, because this woman, Pam Pontonis, really got me very nervous and scared about what the possibilities were in the country and our national security implications. And so she really planted that seed in me. And so I have mentioned her name more than you can even imagine. And she is nationally recognized. And so we're so fortunate to have her today. And that's how I got engaged in this, is because of her and Dr. Kane, truly. So I look forward to your presentation.
Thank you, Susan. Dr. Box, are there any opening remarks that you would like to share with us today before we start the rest of the meeting?
Absolutely. A couple of things. But first of all, let me just say it strikes fear into the heart of the State Health Commissioner when Pam Pontonis shows up on a Friday afternoon about 3 o'clock to tell you about our most recent outbreak of whatever it is, or text you on December 31st, 2019 and says, we may have to keep an eye on this pneumonia in China. So she's 32 years of service. That's a lot of years to serve public health. So thank you, Pam, for that. I think today's discussion about governance and infrastructure and public services, the health services that we need to have across the state, is very, very timely. I'm sure many of you know, and I'm sure Brian can underscore this, that this is one of the most difficult times in the pandemic that we are facing right now. Our hospitals have been at the highest census that they've been in 5 years since April of this year. They have lost a tremendous amount of their workforce. They are exhausted and facing another holiday season with lots and lots of sick Hoosiers. And that hospital census is not just COVID, it's other people that have had heart attacks or strokes or need cancer surgeries or whatever. And it is a very difficult time right now. And what I would say, we don't know what the Omicron or Omicron, however you want to say it, virus is going to, that strain is going to bring to us. What we do know 100% is that getting vaccinated and getting your booster dose will help to protect you from getting hospitalized and from dying from this. And that's what we owe our hospitals. That's what we owe ourselves, and that's what we owe our families. I want to say, too, that, there's a lot of other public health things that are going on. And I want to say, we've talked a little bit about how do we regionalize and cover from one county to another. And I know Dr. Kane has been a great representative of that, in that she has frequently loaned out her mobile van, her personnel, her translators, the people to be there and help with Spanish or Burmese or whatever. And that's a tremendously important thing for our communities around the state. I will also say that Mindy shared, and I love this, I could just see her kind of in the van with her telephoto lens and, following up a story about how someone was, tanning hides or doing something, and it was causing a smell and the release of blood, and no agency seemed to want to own it. So of course, Mindy owned it, and Mindy solved it for her community, which is important. And that's the kind of fill the gaps that we see across the state. And I want to share one story about a county, and they basically had lost their health officer. So another health officer from another county had stepped up and said, we will be your health officer. We'll handle this. Since that time, they've lost their registrar. So that's the person that does the birth and death certificates, their public health nurse, their emergency preparedness person, and the person that does their septic permitting. So we had a health officer covering another county, not even our own county, that reached out and said, I need help. And we had counties step up. We can help. We're in the process of having a meeting next week to help organize this. But that type of sharing of resources and regionalization and support is what we're here, I think, really to talk about, and how we can make sure that every county has the baseline public health services that Pam's going to talk about, and is able to even do above and beyond those important things like community engagement and communications and planning, those other things that they haven't had time to do because of the lack of funding, the lack of resources, the lack of workforce. So thank you very much. So I'm looking forward to hearing from you, Pam.
Thank you, Dr. Box, and we're really appreciative of everything that you all are doing right now during the current situation here at the State Department. And then I know all of the healthcare providers and the local health departments. Indiana has, I don't know, everybody wants to claim, at least on the national news, which state is doing the best job, but I don't think that anybody has approached this with more diligence and more commonality of an agreement of purpose from top to bottom than the folks in our healthcare industry in the state of Indiana. So I think that gives us a good base to, if we can come up with a good recommendation for this for the legislature, I think that's the way we can sell all this. And so we really appreciate your efforts, and our thoughts and prayers are behind you as you move forward.
Thank you.
So Shane, could you give us some information on the public comment summary? And you might also point out the list that we have for our listening tours and where we are with that. If you could give us an update on where we are in that exercise.
Sure. So on the public comments front, we received 7 comments from 4 people. We had a very passionate individual who spoke mostly about trauma support for emergency preparedness and making sure that we invest in volunteers, providing support and training for them as part of the public health system. We also had another individual comment specifically about emergency preparedness, making sure that there's better funding for public health and disease prevention specifically. And then our last 2 commenters spoke on topics of privacy and making sure that there was appropriate representation for rural health initiatives. Of course, Dr. Veal being here representing the Indiana Rural Health Association. I'm sure we'll continue to have that input as we move forward. Specific to the listening tour, if I can find my list here, we did give you an updated map of where we're planning to go, essentially the first 3 months of 2022. You'll notice that the locations chosen are a little bit different in that they're not necessarily always the population centers that you might think we would go for these types of things. And that's intentional, one, to make sure we have broad representation and that we're hearing from voices across the state, but also to make sure that we appropriately represent some of these concerns from the rural segment, that they are getting their voices heard and that we are not necessarily making this recommendation for Indianapolis, but the state as a whole. So the 7 sites that we are planning are Monticello on the 7th of January. January 14th, we'll be at Gary. On the 28th, we'll be at Plainfield. Then we head south to Jasper on February 18th. We'll go to Newcastle on the 25th of February. In March, we'll be in Seymour on the 4th. And then on March 11th, we'll go to Huntington, and that will conclude our listening tours. We are in the process of putting together some parameters for that. We are hopeful that we'll be in a large enough venue that we'll be able to accommodate folks to come in and provide testimony, probably with some parameters around a time frame of 3 minutes or so, with the option to provide written testimony as well. And of course, this all supplements what we have today in terms of the public comments option online. So really multiple ways for people to interact with us. And of course, as folks interact with you, we're hopeful that you'll bring that back to us and share that so that we can get that included in the record. Any questions?
Yes, sir.
What time will these be held, or will that be forthcoming?
It'll be forthcoming. We think it's going to be an afternoon time, but we want to nail down some logistics before we commit to that.
Will you send that out to us in case we want to attend?
Absolutely. Yes, sir.
Okay, thank you.
And I think, Shane, aren't you planning to contact certain people in each region that you think may have something of value added that we need to hear about at the meeting, so that there will be some structure to this in addition to the general public's opportunity to appear?
Yeah, that's correct. We are extending invitations. Of course, it is public, but we're specifically inviting community members, local officials, individuals representing K-12 and so forth, so that we have broad representation outside of just the traditional public health space.
And Shane, will you want other members of the Health Commission to attend one or several of these meetings, depending upon where it's located?
Absolutely.
Okay.
Bob will probably look this over and send you all some notes of this is going to be in your area. We'd kind of like to have you there with us if you could,
Yeah,
type
we do.
of a thing. So, any other questions about that? Brian, welcome. Pam, Hannah, welcome. Thank you. Let's see, Commissioner Mark Bardsley, you have the floor for 5 minutes for your comments on Indiana's public health system. I hope 5 minutes is long enough.
For a preacher, it's never long enough. Thank you to our chairs and our health director for moving this commission along, and to our distinguished commissioners, thank you for allowing me to talk with you a couple of moments. And really, what I would like to share is pretty much a snapshot of where Grant County is and our understanding. But to do that, I think that if we would just look at the most recent census data, Marion County is our number 1 county with 977,000 and a few more added to that. I'm rounding off. Hendricks County, Commissioner, is in 9th position as the 9th largest county in the state. Grant County comes in at 25th. We're in the upper 3rd, and we would consider ourselves more rural than most counties. Jefferson County, Madison, the city of Madison, they rank at 50th in the state population. And then our lowest ranked county, the 92nd county, would be Ohio County with 5,900 people. And so we really, when we're talking about the health issues, we're not talking just about apples to apples, we're trying to compare apples and oranges. I think we're comparing apples to cran apples and oranges to maybe nectarines or something else. We are not the same in any concept of the idea. And we've already heard in this meeting as well as others, all should have the greatest health advantages. And I'm not picking on Dr. Kane, I'm praising her. We should have as many of those advantages as Marion County does for Hendricks County, Grant County, Madison County, all the way down to Ohio County. And I believe without any question, that is what this particular group is after. So let me tell you a little bit more about Grant County. We currently have 9 full-time personnel plus our health director. That would include 2 environmental health specialists, a nurse, a public health nurse, a food safety officer, vital records clerk, a secretary/billing clerk, our food safety officer, officer manager, and /registrar, as well as 2 part-time full-time grant paid individuals. And just to add a little humor here, Dr. Box, within the last 2 months, we have actually inspected railroad cars. I went back and I checked just because we talked about it last time. So the question is, where should we be going in public health? And I had a long discussion this past month with my health director, and he says, we really do not know what we don't know when it comes to what is available, how we can be more proactive at the local level. And I think that's a challenge, and it's a frustration to our health directors, because once we get past the metropolitan area, we are trying to survive in our health departments and just get the basic work done. And so that's a real challenge to us. For example, in 1990, Grant County had 6 full-time nurses, as well as, 4 full-time nurses and 6 part-time nurses that worked out of our health department. We had a population of 74,000. So we've dropped about 8,000 in population. We have 1 nurse and 1 health nurse now. And we could actually use another one if we could find the funding. And I'll tell a little bit more about what we would use that nurse for in the future. But we are not doing any more than what is required. We're treading water with our current staff and demands, and that's a community of 66,000 in our county. So anybody south of us, I'm concerned because I know what we're doing. I was surprised and disheartened to learn that 65% of births in Grant County are out of wedlock. And that implies some things that with that discussion with my health director again, he proposed that we are fighting generational poverty in Grant County, and it just seems to continue to feed upon itself. And all of the offshoots and forks of those couple of issues start impacting our health issues. So I think we need to be paying attention to that. Some of our local challenges, I've already noted the extreme difference in county population and service, and there really needs to be, and we've already mentioned it again, it's in my notes, we need a better understanding of rural health to see what those challenges are for our smaller communities. If we were to add 1 more full-time nurse, we could focus, that person individually could focus on childhood immunizations, assisting with testing with STDs. We actually have to send some people outside of our county because we can't do the testing for the STDs. We could have TB case management as well as lead investigation that was going on. We cannot do that efficiently and effectively the way we are right now. From my personal perspective, if we had someone, much like Indiana Homeland Security has liaisons for fire, police, and even the health department has preparedness, that is a liaison. If we had, besides an epidemiologist for our regions or our districts, a nurse that could move around from county to county and actually roll up their sleeves and work side by side with our other nurses, I think we would have a better understanding from grassroots up to our head office and administration of how we need to be more effective in the field. Um, One more thing, things that could hurt our local efforts, unfunded mandates, as well as poor information transmission from the top down or from the bottom up, as that would go as well. And I do have one last issue. I probably have already exceeded my time. The chair's been very gracious. But in our state meeting with the county commissioners about 2 weeks ago, I don't know if Commissioner Dawes had picked up on it, but we had a meeting with the two leaders of the houses during that time, and they mentioned, they just kind of dangled the carrot and said, we may be reducing taxes, lowering taxes in the state of Indiana. And immediately a flag came up in my mind and said, we are talking about having to fund a whole new generation, a whole new methodology for public health. Why would we consider reducing taxes at this time? I know that that's always a positive thing, but at the same time, if we step out, get rid of those taxes, and then we say, oh, but we have to fund public health, that becomes a major concern for me that we've really shot ourselves in the foot across the state. So those are my concerns, and thank you for letting me address them.
You bet. Thanks for sharing your thoughts. Bob, Courtney?
Well, thank you. And I'm also going to echo some of the thoughts from Commissioner Barsley, but a little background, I'm serving my first term. So in my first 2 years in public office, we have dealt with natural disasters. We have dealt with public safety issues that were larger than before. We've dealt with a homelessness crisis in our community. And then on top of all that and the other things that we're doing, we had the pandemic. And the pandemic has not only overwhelmed, as Dr. Box was talking about, our healthcare systems in the community, it's really overwhelmed all of the infrastructure across the community, from leadership to staff to schools to public safety officers. And it's exposed where some of our weaknesses have been, particularly lack of historical investment. That's really what it has exposed. My wife is a veteran intensive care nurse, and so our evening conversations generally have always been, for the last 2 years, focused around what are we experiencing on a daily basis with regards to our response, how can we improve it, how communication has been, what the data is like, what news is coming out. And there's still a tremendous unmet need, because while we're spending a lot of our focus on the COVID response and digesting dozens of executive orders and public health recommendations, we're also dealing with actually a continuing crisis with regard to mental health and particularly substance use disorders. And most recently, we have a surge of not only drug crime, drug-related crime, but overdose and overdose deaths because of fentanyl being marketed across our community. And so we're constantly dealing with an emergency response every day, even outside of the pandemic. My observations, and I'm grateful to be able to serve on the Public Health Commission, because once we get to the part where we're really communicating out there with the community about the importance of what we're trying to accomplish here, I think that it'll certainly be prevalent that our local health departments are overwhelmed and tremendously under-resourced. That is just a given. And we've talked about taxation before and how our local health departments are funded, but try to wrap your head around the fact that our county local health department is funded with 1.5 cents of assessed value per $100 from the community. 1.5 cents. There's hardly anything else in our community that is a lower priority, frankly, than our public health. Our health department has to go out and find other sources, grants and alike, to be able to operate, because such a small part of what we commit as taxpayers caring about our community is coming from our investment back into the community. And echo the commissioner's remarks, we are also having conversations with our local legislators who, for probably very good reasons, are talking about tax cuts. So there's always this paradigm and this conflict, which is, but we need more investment over here. How can we reduce revenue, or why should we reduce revenue over here unless it will generate more revenue? On the governance side, one of the things that I've learned too is that there hasn't been enough engagement on the government side. And what I mean by that is Madison is the county seat for Jefferson County. We are the most populous, dense community in the county. And we have a lot of migration of people coming into the community to work. And we have a lot of tourism. We have a lot of people visiting. So it's really a multiple of our population every single day. And so our needs are more than what our population would indicate. Our population is around 12,600 people. But we are not represented properly on our local health department board. Third-class cities do not have any appointments to local health departments. And so as we were embarking on strategy and dissecting policy and trying to respond to Governor Holcomb's executive orders and all the news that was coming out, there was always this dichotomy of public health and public policy for our economic reasons. And over time, that created friction. And I think that two things need to really happen, and I hope these are outcomes from the Public Health Commission, and that is we've got to expand engagement and recognize there's a lot of stakeholders that are involved in the decision-making process, and we have to make a much greater investment than we've ever done before. And with those two things, I think that we have a shot at being more successful. But as the commissioner said, we're also now dealing with what are the future repercussions of what we're incurring now that are yet to be identified, that may not be experienced fully for years to come. We're already playing catch up in many regards with regard to public health, and this has layered on a whole new dimension, but also created a lot of opportunity for us right now to deal with it and be prospective and think about the next 10 or 15 years. And we're in a good position financially to make the right level of investment. And so I'm optimistic that we'll get there, and that we do have a good legislature that cares about our communities, and we'll work hard to have our voices heard and represent our communities as best we can. Thank you.
Thank you, Bob. Thanks for serving. Next, I'd like to recognize Kim Irwin, who represents the Indiana Public Health Association. So, Kim.
Sure. Thank you, Chairman Kenley and others, for the opportunity to offer a few remarks on behalf of the Indiana Public Health Association. So thrilled to be part of this commission, and so just appreciate the opportunity and being here with you all today. So in 2022, the Indiana Public Health Association will actually celebrate its 75th anniversary of the original forming. We are the state affiliate of the American Public Health Association, and so through that have access to the network nationally of affiliates and connections there. We are a membership association and governed by a volunteer board, which is currently chaired by Ellie Hansot, an epidemiologist at the Marion County Public Health Department, and about 12 or 13 others who offer tremendous expertise and experience across a range of sectors. We have more than 225 members, when those consist of organizational members, professionals and practitioners in the current workforce, retirees as well, and then student members. And that student membership pipeline is incredibly important, not just in engaging them in sort of the public health world, but setting up career paths and advocacy opportunities and that kind of thing. Many of you may have known Jerry King, who served as the long-term executive director of IPHA for more than 20 years. In 2019, Health by Design began managing the Indiana Public Health Association, and so I do serve as the executive director in that role. Through a strategic planning process we underwent around that time, and then since, we have really strived to achieve our mission around building capacity for public health practitioners, professionals, and partners in achieving health equity and well-being for the public across the state of Indiana. And we do that by really striving to be seen as and valued as a robust connector, a partner, and a resource for professionals, but for others as well. I'm going to share a little bit about the work that we've been doing, and what I think you will see, hope you will see, is the alignment with the exact things we're talking about here. And I think that does speak, not in any way that like we know all the answers or we have everything, but it speaks to how important and critical these issues are, and how sort of developmentally over time these have emerged as core critical public health issues in Indiana. And so we speak about much of the work that we've been doing as shifting upstream. And this upstream downstream continuum may or may not be familiar to some of you. I'm happy to explain more and share some resources. But if we think of downstream issues as sort of the problems themselves, right, especially around health, tobacco use, maternal child health issues, the behaviors, the disease states, that kind of thing, we know that we need to be treating those. I always say we need to ensure people that are hungry are eating today. We need to ensure that there are roofs over the head of people that need that today. We need to treat clinical issues today. And we know that by focusing there and directing tremendous resources there, 97 cents of every dollar in the healthcare system, we are failing to address the root cause issues. And so it is insufficient to focus our efforts fully downstream when we know that these upstream issues, which if we keep going upstream, the further you go upstream, you recognize then not just infrastructure, not just resources, but the role of cultural norms and kind of societal norms, cultural views, things like racism and other forms of power and oppression, and how all of those things are impacting the structures, the systems, and again, that infrastructure of sort of how we operate societally in our governmental units, in our schools and homes and work sites and places of worship and such. And so when we can shift that conversation and shift the focus around what does it mean to address funding for public health, right? What does it mean to address structural racism in various ways? What does it mean to address workforce capacity and training and education and those kinds of things? Then we can begin to build that, not just the network and the system, but to begin to shape those downstream outcomes, again, that consume so much time and energy and resources and effort because they must. The needs are significant there. The other thing that I'll just offer is that I often talk about how we do things is as important as what we do. And so when we think about even funding or, again, addressing workforce development, those are topical, right? Tobacco use, maternal child health, topical things. How we approach doing things then becomes extremely important. We're dealing with the need for complex systems change, right? And complexity theory and systems change theory, like those require different interventions, different ways of approaching the problem than frankly we're typically used to doing with more simple or technical solutions. And so that's where then the focus becomes, and going back to some of what we've been doing, a focus around what I'll call for today several C's: convening, connecting, communicating, collaborating, coordinating, creating policies and programs, creating opportunities, creating those things. And so I've been saying a lot, some of you that have heard me of late, like we need people who wake up each day thinking about the system, thinking about systems change. And hardly any of us in our day-to-day work have the opportunity to do that. We're so busy focused on what's in the job description and more, exactly the points you all are making. And what I'm hopeful that we can get to through this commission and broader work, it absolutely will take out all of us across all sectors, but is that we begin to build systems where we have folks who are focused on the how as much as the what, and that ultimately then leads us to be able to address the issues, the problems that we know we have and that we want to solve desperately, all of us, and to do that in a collective way. So I will stop there. Again, just thanks for the opportunity to offer some remarks and to contribute here, and look forward to the work we'll do in the months ahead.
Thank you, Kim. Now we're going to hear from Pam Pontonis on the infrastructure, governance infrastructure development. This is a nice presentation. And then when we get done with that, why, if you have questions of any of the folks that have gotten an opportunity to make some comments today, as well as Pam, why we'll dig into that when we have our open discussion. So Pam, thank you for being with us today and for preparing this report for us.
Thank you so much, Senator Kenley, and welcome everyone, all the members of the commission. It's my pleasure to speak with all of you this afternoon. And thank you also for the wonderful, kind words. I truly appreciate those. It's been a wonderful journey in public health. I can't state that enough. And speaking of thank you, I want to make sure to thank all of you who participated. And I'm not sure exactly. Is it, which one? As my boys will tell you, I am not tech savvy. But a note of thanks to all of the folks whose name you see on the slide. Several of you on the commission took your time and effort to participate in several interviews that we used to gain information to inform this presentation today, as well as local health departments who participated in a survey. And the data you will see from that later on. But I do want to thank all of the folks who gave of their time and expertise. I also would like to thank Kathy Gifford and Lori Matthews from Healthcare Management Associates. Their help was absolutely vital and tremendous in preparing this presentation today.
Pam, you have a very soft voice.
Do I need to speak up?
Speak up just a little bit, or we need to have our mics turned up just a little bit if we could.
There we go. Is that better?
That is better.
All right. Thank you for letting me know.
Go to the hearing aid.
Maybe we need a quantity discount.
So this is a quote that we found that we really like, and it comes from Grand Challenges in Public Health Policy. It was published in 2015. The challenge for public health is ensuring that our governance systems meet our current public health needs and demands. Public health policy and practice is constructed and realized at many levels simultaneously: local, regional, national, and international. We've certainly seen that through the pandemic. All are important, require different skills, and should be linked to maximize effectiveness. As the context for public health changes, institutions will need to be reinvented and new networks formed to bridge the gap between these levels and to stimulate new communities of learning and action. And I think you've heard that reflected in some of the remarks that have already been shared with you today. So in looking at governance, state and local health departments, if you look at the federal Constitution, the public health is not explicitly denoted in the federal Constitution. It is primary responsibility of states to govern public health in their jurisdictions. So state and local health departments retain the primary responsibility for public health, and that works all across the country. There are several roles, though, that the federal government plays, and we've certainly seen that throughout the pandemic and in many different ways. Leadership in collaboration with state and local governments, other stakeholders, in setting public health goals, policies, and standards. We see that through CDC, we see that through FDA, USDA, several different national organizations and agencies at the federal government level. Federal government provides operational and financial resources. We've seen that through the many grants that we receive, assistance to states lacking expertise to respond in a public health emergency. I can tell you right now, as we speak, we have a CDC team deployed on the ground in Evansville, assisting us with a syphilis outbreak that is ongoing. We've had in the Scott County HIV outbreak, we had CDC deployed to assist us then as well. So certainly a tremendous resource role that the federal government plays. Financing for research and higher education, support for the development of public health scientific and technological tools, And certainly the federal government can act when health threats may span more than one state. And we've participated in more federally organized and coordinated investigations and responses when we see that happen. In terms of governance locally in Indiana, and we've mentioned this before, I think Dr. Bach shared this in the last presentation last time, Indiana is a home rule state. We are a decentralized state when it comes to public health. So the local health departments have local autonomy over public health. They have the complete legal jurisdiction over public health in their counties or in their municipalities. This is actually a pretty common structure, governance structure. Indiana is one of 27 decentralized or largely decentralized states where local government employees, local health departments primarily lead those local health agencies, and local health governments retain that authority over most key decisions. In terms of funding, as you heard Shane present last month, local health department funding control in Indiana rests with county councils, unless they are the recipient of grants directly from State Department of Health or CDC, a federal government agency. The governance classification that you see here, whether you're decentralized or a shared form of governance in different models in different states, is determined based on a pre-developed classification of state health agency governance to describe those relationships between the state health agency and the local or regional health departments. So some states are centralized, some are decentralized or shared, and you see the majority, actually like Indiana, are decentralized. So again, local control, local jurisdiction over public health issues in that county or municipality. Okay, maybe having some technical difficulties again.
Want me to do it from here?
That might help. There we go. So thank you so much. So in Indiana, most of Indiana's 94 local health departments serve populations of 50,000 or less. And I think we heard Commissioner Bardsley, or Mayor Courtney give some examples of that. This count of local health departments, and you see the breakdown given there in the chart on the slide, where 39 actually serve fewer than 25,000. 35 up to 50,000, and then they go up from there. This count includes both independent and state-run local health agencies. And you can get an idea that in Indiana, we have 91 county-based local health departments, one per county, with the exception of one that is shared by Fountain and Warren counties. And then we have 3 municipal health departments in East Chicago, Gary, and Fishers. In looking at a decentralized model of governance, there are several strengths and weaknesses, and again, would like to thank those of you who participated in the interviews for really sharing what they thought were the advantages and disadvantages of that decentralized model. And what we heard in terms of advantages loudly and clearly was local credibility and being a trusted resource in the community. Folks know their local health department. They see them as an authority. They see them as being a member of their community and a trusted resource. They have a physical presence where people have access. They have established relationships in the community with stakeholders and can call upon those relationships and partnerships when needed. Because they are local, they are able to be more responsive to local public health needs, especially quickly. They can provide that quicker response time. Some disadvantages that were noted, particularly in our interviews, included that though funding is primarily the responsibility coming from the county councils, folks on those councils often lack an understanding of what public health really does. So what does public health do? I'm not really sure, but that's where the funding's coming, so there's a little bit of a disconnect. There may be inconsistent availability of resources or expertise or training. We heard about Some of the smaller, more rural health departments have limited staffing, and they may have limited experience or knowledge base, especially for some of the newer priorities that we're seeing in public health. There can be inconsistent enforcement and messaging of different public health issues that will vary county by county because they are all independent. And then also noted was an inability sometimes to respond to emerging or growing needs of refugees and homeless, sometimes populations that might need additional support, especially as those populations grow. Local health departments may not have the resources or the knowledge base, the ability to be able to handle that. What we also heard is that local boards of health are very important for advocacy for their local health departments and are correlated nationally with increased funding. But today's system in Indiana doesn't always allow counties to incorporate all of the different needed skill sets into their local boards of health. One example being epidemiologists or someone with epidemiology background and skills. We heard that in counties where local health departments work well with their county auditors, they have a good relationship with the county auditor, funding works more smoothly, and that makes sense. The iron triangle, if you will, of communication with executive, legislative, and fiscal bodies is critical. If a local health department has those established relationships, that process works a lot more smoothly. So counties need a consistent framework of why that's important, and public health is everyone's responsibility. It's not just the local health department. So shifting a little bit to infrastructure and services, in an overview of all of the different statutes, and Mindy did a fantastic job pulling all of this together, I think it was last month, in looking at what public health services currently are covered by Indiana statutes. We find that there are several, and I won't read them all, that you can see them on your slide. Several are mandatory. That we have currently. Some are non-mandatory, but are performed commonly anyway. And others are more locally driven, based on the desire and the need of local jurisdictions. And looking at what we heard in our interviews, there were a few areas of strengths that were particularly noted up front. First being vital record services, so birth and death certificates, food protection and inspections, so restaurant inspections and being able to make sure food is safe. Another area of strength, childhood immunizations, adult immunizations. I was a little concerned not to see communicable disease in there, but we did hear that local health departments, that is one of the top things that they do as well. Non-mandatory, if you can take a look down there toward the bottom of the slide, we heard some inconsistency, maybe some areas of improvement, or maybe we just don't do that enough to really have a good grasp of how well that works. And what we heard, tattoo and body piercing, safety and sanitation, STD, sexually transmitted disease, HIV prevention, which is really critical. So testing, treatment, partner services, and then syringe service programs we heard were maybe some areas of inconsistency, how those should be governed, how they should be offered. So we have some areas of statute where folks felt that right now we're doing a good job in terms of those services being performed. Maybe others were doing pretty well, and others maybe we have some room to grow. So one of the things that we wanted to look at very closely, and we've heard through other presentations that one of the goals or one of the premises is being able to offer public health services, a foundational level of public health service, no matter where you live, that every Hoosier should be able to access a foundational level of public health services, no matter what their zip code. And we've heard that local access is very important, that essentially having a footprint of local public health in every county is very important for that access and for equity. And keeping that at the focus of what we do. If we want sustainable funding for governmental public health, we have to define what that funding would pay for. what is the core or the foundational level of public health service. For example, health insurers describe their minimum benefits package. So what would be the minimum level of public health services that we would expect to be offered in every jurisdiction? There are different frameworks for this at the national level, and we found one in our research that several states, including 2 of our border states, are using, and that is the foundational public health services model. The foundational, and you have a handout in your packet today that goes into some detail. I would encourage you to take a look at this because it is something that several states at the national level are starting to embrace. Foundational public health services define public health services that no community should be without, no matter how they might be provided, whether that's by state, regional, local government, or some form of shared service. Like public safety or public utilities, foundational public health services must be in place everywhere in order to work everywhere. This framework actually originated in 2013 through the work of the Public Health Leadership Forum that was founded by the Robert Wood Johnson Foundation. This body of work now is housed at the Public Health National Center for Innovations, and you have a handout on that as well. That is actually a division of the Public Health Accreditation Board. So you have some good synergy now linking foundational public health services to accreditation. And you can see that there are some cross-cutting skills and capacities needed to support basic public health protections, as well as foundational areas, those topic-specific programs that are aimed at improving the health of a community affected by diseases or public health threats. Sure.
Pam, just it's sort of a history question, but I'm guessing that, if we were to go back, and you don't have to go back a couple of slides, but we were just look at those basic things that are done today. That's not necessarily the result of the Public Health Review of 1964, right? Unlike some other things we've done in Indiana where there have been like property tax reforms or other things where we kind of revisit every couple of decades and kind of adopt a model. I'm guessing we've never gone back in history and said, what are those things? We are still, to this day, this is simply a patchwork of we added this, we added that. And so if we were to take on something, and I'm not necessarily, we've all been just looking at this, but to undertake a review to set those foundational things, this really would be the first time we've ever done that in Indiana. Is that fair to say?
To my knowledge, yes. And you're getting further along in where we're going to go. So no, that's great. Hold on to that because we're going to come back.
It's hard not to think about history in this setting, I guess.
You're exactly right, and we're going to go there. To my knowledge, that has not happened. That over time the statutes have been overhauled. A public health code, and there, at least for communicable disease, for example, was overhauled in 1993. But in terms of a comprehensive, to my knowledge, that's not been done. But thank you for your question. So what is, wanted to continue, why this particular model? What is it about the foundational public health services model that is really gaining the attention of states? And you can see on the map on the right of your slide, there are several states that are now adopting, in various stages, are adopting this framework. And you can see Ohio and Kentucky and Missouri that are close to Indiana, Minnesota, also in our Region 5. We'll talk about those a little bit later. But the foundational public health services are based on the idea that where a person lives should not determine the level of public health services available. There is growing interest in exploring that for several reasons. One is that it communicates the minimum package of services needed everywhere, focusing on what services need to be delivered while leaving room for individual communities to decide how to deliver them. It's not a one-size-fits-all delivery, but here's the standard. Now, what works best for your community to deliver that? It provides a common language that can also be used to inform local health department structure or service delivery. So you have at least a common place to start. It can be used to assess or to identify the degree to which the services are being achieved, current investments, and funding needed to fill identified gaps. It can also be used as an organizing tool for strategic planning by identifying the capabilities or programs not being fully implemented that need additional focus or resources. And then it connects clearly to national initiatives such as public health accreditation. A local health department with sufficient existing infrastructure has more capacity to provide leadership and successfully partner in efforts to protect and improve population health. And you say, well, Pam, that's all great, but what are the governance structures around that? Remember, we're a decentralized state. So are all but one of those other states. Kentucky is the only one, and it has a shared model. All of those other 21st century learning community states are decentralized just like us. One other, speaking of accreditation, and the foundational public health services, once those are achieved, can really help a health department work toward that eventual goal of public health accreditation. We talked with representatives from the 3 accredited local health departments in Indiana, Montgomery, Rush, and Vanderburgh counties. We're accredited at the Department of Health as well. And what we heard from them was that all 3 of them are likely to pursue reaccreditation within that 5-year time frame, although one noted that it might depend on funding availability to assist with that. All 3 would recommend accreditation to other local health departments, not as a mandate, but as a recommendation to achieve the highest level of standardized public health service. And all of them agreed that training resources would be welcomed to help them achieve that accreditation. Advantages including increased credibility. If you go to an accredited hospital, an accredited university, so why would you not want your local public health department or state public health department to be accredited, to know that they meet a nationally recognized standard? Enhanced accountability, making data-driven decisions part of the culture. And we saw even in our process where accreditation is a rising tide that raises all ships, that we had to really look at our processes and how we did them. It facilitates goal setting, strengthens community partnership, and it builds staff confidence. I had someone from my own team say, Pam, I thought this was crazy. I thought, my gosh, where are we going to find the time to do that? Until I got into it and realized how much it was helping us. And one of our local health department partners said, we were convinced that we could do the impossible once we made it through accreditation. If they literally said, if we made it through accreditation, we could make it through COVID. Wow. That I think says it all. So taking a look at a little bit of a deeper dive into some states that are using the foundational public health services model. Healthier Missouri. Missouri is an example of a state that is using this model now. You can see kind of the structure base there on your slide. I'm not going to go through all of that. You can take a look at that. It is directed by local public health agencies and stakeholders. This is a grassroots initiative to transform their public health system, again, based on the foundational public health services framework. Their model was adopted in December of 2019, and they did release a capacity assessment recently this past June. And they found that communicable disease was the area with the highest statewide capacity. Near and dear to my heart. That was great to see. Local funding varies dramatically, and the level of per capita funding is driving capacity. And their administrator experience and training really influenced their capacity as well. They use 7 cross-cutting skills that are required to assure the delivery of those foundational public health services and achieve equitable health outcomes. Those foundational capabilities include assessment and surveillance, emergency preparedness and response, policy development and support, communications, community partnership development, organizational administrative competencies, and accountability and performance management. pretty foundational. I think if you look back at what we've done with the pandemic and many different public health issues and initiatives, you would find that all of those are very basic. They're very important. Their model also highlights health equity and social determinants of health as a lens through which all of their public health programs and services should be provided. So you can take, again, more of a look at the handout that you have with you. Ohio also is pursuing the foundational public health service implementation. They actually have a state mandate that all of their 85 local health departments will be accredited. So that's a little bit different than some of the other states. What they found as part of their 2018 case study finding was that adoption of the foundational public health services can help ensure that all Ohioans receive fundamental public health services, and while it's not a direct pathway to accreditation, may help departments in pursuing that goal. So you can take a look at their process now in 2021. House Bill 110 requires cities with a population of under 50,000 with local health departments to study the efficiency and effectiveness of actually merging with some other counties to share services. That's Ohio. Not all states work that way. Kentucky has also defined their foundational public health services. In 2020, their House Bill 129 defined that for them, and a state funding formula. Their foundational public health programs include activities and services that prevent and mitigate disease, protect people from injury, promote healthy lifestyles across all environments, promote population health services, and enforce administrative regulations, ensure emergency preparedness, and some others. They also decided to include some other core public health programs, such as WIC, and their Health Access Nurturing Development Services, or HANDS program, as well as the Substance Use Disorder Harm Reduction Services. Then also coming from that, any local public health priorities that are deemed locally to be very important. Those may include demonstrating data-driven needs, using evidence-based or promising practices, identifying adequate funding, demonstrating performance and quality management plans, and having a defined strategy to determine when that service or program is no longer needed. Being very good stewards of resources and realizing that we don't need to keep doing the same things that we've always been doing, but we follow the data, we use evidence-based practices, and we see what needs to be done. So those are their current local public health priorities, and they have those requirements for them. So to do this, some of the states are using different ways of sharing arrangements or sharing agreements, because they've realized that to provide all of these foundational services, it can be hard to do all of that on your own, by yourself, even if you are a larger, more resourced public health department. And so states have developed a spectrum of sharing arrangements that they've used, and this comes from the Center for Sharing Public Health Services, a roadmap to develop sharing initiatives in public health. It was updated this year. If you move from left to right on that spectrum, the level of service integration increases. So if I'm a local health department, for some things, I may need assistance as needed. You know, I can cover this pretty well, but for the most part, I've got it. Or I might think, you know, I would benefit from having a little bit added staffing. Maybe there I can share a staff member with another local health department and go into a service-related agreement. Or I might decide that I can share a program or a function. TB investigation comes to mind with this. Not a lot of local health departments may have that capacity or need it, but when they do, it's very important. So they could share a capacity for epidemiology or communications or grant management, for example. And then some may merge and consolidate, not really what we were hearing from folks we talked with, but there might be ways to share programs or share resources. Washington State uses different examples of service delivery models. Again, if the models being that the local health department is solely responsible for that given function or activity, for example, on-site sewage systems and inspections or solid waste enforcement. Just about every local health department had that capability. There might be mutual aid or interlocal agreements or contracting for epidemiologists or for communicable disease data dashboards, something like that. Other types of examples of service delivery models, you may be familiar with this, include hub and spoke models, centers of excellence, where we might have state-funded staff embedded in different locations across the state and then serve the different counties or local health departments in that region. Our field epidemiologists and field public health preparedness coordinators would be kind of a hub and spoke example of some shared service delivery. And then finally, centers of excellence, whereby more of an academic, educational entity provides that continual expertise or ongoing education and training for local health departments or health entities. Couple of other models that can be thought about are combination or centralized models. Counties may decide to combine and use a combined staff. Centralized sharing generally coming from the state health entity in that particular example. We found through some survey data that there is already quite a bit of health resource sharing happening with Indiana local health departments with each other and with the State Department of Health. We asked local health departments over the past year, has your local health department entered into a formal or informal arrangement to share any of the following public health resources or expertise with one or more local health departments in Indiana? And they were able to check as many as they wanted. 49 of our local health departments participated, so we were happy about that. The majority, 39 of them, shared at least one resource with another local health department in the past year, and most of them shared 2 or more. So already we have a lot of informal agreements, arrangements already happening. Folks kind of know where to go for help. And often they will do this with local health departments in their districts, their public health preparedness district, or they might go outside if there's a neighboring county that they have a very good relationship with. The most common resource sharing was equipment and supplies, including COVID, testing and vaccine supplies were frequently mentioned. Other responses included personnel, shared health officer, communications, communicable disease investigation, epidemiology expertise. You can read further down. Then we also asked local health departments to indicate any public health resource or expertise that your local health department would be most likely to take advantage of if a resource sharing agreement with one or more were readily available. So these are the resources, the areas that they would really like more help with. And we found that 42 of 49 indicated they would share resources with one another if they had the pathway to do it. And half of these would share 4 or more resources. Communications expertise, epidemiology expertise, communicable disease investigation and reporting. Data analytics was another one that local health departments wanted to get more shared resources. Translation services, equipment and supplies, environmental inspections, going down the list. And then almost all of the Indiana Department of Health resources listed were interesting to a pretty large number of local health departments. So when we asked local health departments if they would consider taking advantage of any of the following services or supports, if they were provided or made accessible by IDOH, we got quite a lot of responses. So it helps really inform our team. We saw that 46 out of 49 would really appreciate more legal guidance and expertise, expertise on enforcement, communications, human resources, more of those operational types of services that they may not do as often to be that proficient, or they have enough turnover in staff where they're having to find training and relearn it. Communicable disease, investigation reporting, data analytics, IT, accreditation, again. So to conclude, we have some considerations to mention to this commission and maybe some questions to leave with you all today. So in looking at future recommendations that you might develop, to consider access. How do we ensure and maintain public access to a local health department in every county so that no matter your zip code, folks have equitable, consistent access to a foundational level of public health services where they live? Ensuring a defined set of core public health services and capabilities. What are those? And making them available to every Hoosier. Determining the feasibility of resource sharing. Understanding that local health departments are resourced differently. We certainly heard some great examples from Commissioner Bardsley and Mayor Courtney. Understanding they are resourced differently from local funding, grant funding, and many of them serve fewer than 50,000 population. Can service and capability gaps be filled through resource sharing agreements? Already happening quite a bit now. Can we formalize them? Should we formalize them? And if yes, what are those opportunities to formalize those arrangements? Considering accreditation. What state policy and supports like training or other resources be made available regarding accreditation for local health departments? Is that something that as we build on these foundational public health services, we would like our local health departments to achieve? And then finally, wrapping back to what Brian mentioned earlier, consider an assessment of our Indiana code regarding public health. What changes, if any, should be made in our public health code? Does it need to be modernized? Do we need to do that comprehensive assessment to determine what is necessary now based on what we've learned recently through many different public health initiatives and issues? And with that, I would like to thank you all very much for your time and attention this afternoon.
Thank you. Thank you, Pam. This is really nicely done, and I think very timely for the commission. I have to say that on your last slide, number 26 there, the items that we have in red there, access, minimum, public health service, feasibility, accreditation, modernizing the code, we probably need to answer all of those questions in our final report. So with that, I will open the floor for questions for Pam or from our other commenters. Kim?
Sure, Pam, just with the current activity of sharing resources, had we surveyed that ever before COVID? Because anecdotally, my understanding is that through the COVID pandemic, some local health departments that had never done that before are doing it now. And I think that's just an interesting point, if we know.
Sure, and that is an interesting point. There was a degree of resource sharing already that was happening that we've heard informally and anecdotally pre-COVID. Certainly COVID, I think, really caused everyone to take a look at their capacity and, oh my gosh, how can we make this work? And you saw quite a number of health departments reaching out to one another. We heard some great examples that Dr. Box gave that Dr. Kane has been doing with Hendricks County, Vigo County, when we look at being able to bring a mobile van in to assist what's happening with another county. So I think COVID really shone a spotlight on that and propelled folks to really look at that a little bit more, especially when we're all in the same boat. How can we drive a bigger, better boat? So that really kind of brought it up. Yeah. So I think, and as a result of COVID, I don't think that's going to go away, nor do I think it should. I think it can provide a roadmap for what we can do in the future. Yeah. Thank you. You're welcome.
So Brian, would you restate your earlier comment there I wasn't really tracking on what you were saying at that time. I was still trying to understand what she gave to me. So,
About kind of the historical
Yes.
element of this. Well, I was going to actually also say, if I might, that this, I think that slide in particular about the desire to share, I think also helps reinforce the suggestion that I made before in terms of just, which is not unique, looking at kind of regionalization. But I think I just wanted to say, these are some of the very same things that Dr. Kane identified as the most, kind of the low-hanging fruit of collaboration. And so I think this really validates some of the conversation that we've already had about potential for shared services. I think what I was trying to sort of say before, and I didn't know the answer, but is that the exercise that we're potentially all doing here, are doing, of a overhaul is kind of unprecedented in the sense that there's never been a review like this. We've
Okay.
gone through, I always think, not just because you're here, but my history about property tax reforms,
Right.
and all of these different times where every generation or every couple of decades, we look back and look at some criminal justice reform, right? There have been these periods in time where we have said, we got to go back and kind of take a look at this and have this effort. I don't think we've ever done that with public health.
Okay.
So I think to me that underscores the importance of this work,
That's a good point.
but also just how really how much it's needed, because really everything we have, even those standard items that all of the health departments are doing, that's not the result of a scientific kind of researched effort like we're doing now. That's just, we kind of tag things onto the tree, along over the years. And so I think it's pretty profound that this would be the first time that we would step back and say, are those the right things? So
I think
Congresswoman Brooks said we had a review in 1949.
Well, wait.
I have that document.
you think that's right?
Yeah, I have it. It's like a book.
Right.
And it's the last time that they looked at it from front to back. Now it was more about the rules and they changed a few things, but that's the last.
Well, I was going to say
Wow.
a review does not mean action though. So I think
That's
that.
a good point.
So were you here for that one?
My husband would love that.
You gotta write that down. You owe him one.
I just have a question, and please forgive my ignorance if this is obvious to the majority. But on slide 25, one of the top areas of interest among the local health departments and
Right.
IDOH resources was the enforcement. And so I'm wondering, what is that, how is that enforcement defined, and what is that talking about, and how does that relate to slide 11, where we see those services or those activities, I guess, that are mandatory? And if those are mandatory of local health departments, but yet they want state to lean in on enforcement, I'm trying to understand how that could possibly even work.
Mindy can probably talk really well.
You want to go
to it.
first? Or?
Go ahead.
Well, actually, being a county health officer, we reach out to the State Department of Health and thank you for all the help we get. She should never have given me her cell phone number. But a lot of times it may be something new. We don't know how to handle it appropriately. We don't want to say you have to do A, B, and C if it's not in statute. There may be a stepwise process how you deal with that problem or that infraction. So you don't want to jump the line. You want to make sure you take the proper steps. And quite frankly, many of the county attorneys aren't familiar with it either. So we reach out to the State Department of Health, say, okay, we've got a problem. We know it's an infraction. Can you help us work through the enforcement process? So the county will do the enforcement steps, but many times we need guidance. And sometimes it's like, yes, it's an infraction, but don't go with a big club yet. Why don't you go with these remediation steps first? So we're not asking, counties aren't asking for the state to step in. Well, sometimes we'd like to, but quite frankly, it's direction. is this really an infraction? What are our options? What steps because you want to make sure you don't step out of bounds. But that's how a lot of those, and you can correct me if other.
You're absolutely spot on, Dr. Welsh. Mindy, go ahead.
If I could add on, typically enforcement of any of the administrative rules or the statutes are left to the local health departments to define in their local ordinances. So whether you go through a court process or a fine or whatever, your locality chooses to do, most of that is not defined in the rules. So it's not consistently done. And even when those provisions are provided in local ordinances, those are hard to carry out as a health department who sometimes is not respected, doesn't have the authorities that they need, doesn't have the backing of folks. So it's difficult, and we all do it differently. Some don't do it at all because they really just can't. It's a very difficult thing because there's a lot of folks that then call you and say, please don't enforce that. That's my friend, my neighbor, my whatever, and can you just let that go? And so they see a lot of pressures. What we would all like is from the one you saw top was legal, and the second you saw was enforcement. We always ask, can we get guidance on the statutes and the rules you write? Can you tell us what steps we can do, and then can you help with that? Because some just really can't. And that's why we always say those are our two biggest needs, because we're looking for consistency. You don't want to have an infraction, as his word was, in his county being enforced one way and not in ours. And that is what happens. So definitions are not there unless you do that locally.
And we really saw that happen quite a bit with COVID, is where it really came into play.
Happens now.
And quite frankly, one example was just, yes, they were wrong what they were doing. And it's like, okay, don't throw the book at them. Let's have a discussion first. And we might be able to resolve that without having to get lawyers involved in courts and things. And quite frankly, most of the time that was the case.
And my comment, a bit tangential, but I think is important, is that part of what we saw with Senate Enrolled Act 5 then last year, with the state stepping in and starting to sort of set some parameters around that, is that local implementation does look differently. And so then that patchwork of different counties doing it different ways sort of created even more confusion with that. So, yeah.
Mine's a different comment, Pam, and I don't know if Paul may be able to speak to this too. Doing the accreditation process for like smaller health departments, have we seen a model that says what are the core essential services that a small health department must have in order to be a health department? And so, I was just thinking about Grant County, where you have just one public health nurse, but maybe just like when you're doing food inspections, you have to have so many inspectors based on how many restaurants you have to inspect. And so that's the same provided to how many clients you have to serve. What are those essential number of public health nurses? Because, she goes on vacation or she gets sick, what's happening there? Oh, okay.
Sure. So if I'm understanding your question, you're asking, is there something as granular, is there a certain number of public health nurses per capita or environmentalists?
What for a smaller health department?
Yeah.
What's the core number of staff and type of staff you should have in running a health department? And our problem is, because all of these different governments locally, they have their different ideas related to what that is. And if there's no recommendations out there for them, we're going to be caught in past generations' perspectives and expectations, where it's harder to ever change that. And secondly, this is the big elephant in the room, is we got to do something about salaries. So just because you make that salary, wow, 25, 30 years ago, and it hasn't increased, that's a huge problem. But I'm telling you, that's a perspective that is very strong in our local communities, and you pay for what you get sometimes. And so I love Dr. Maxey here. We're going to be having some funding in looking at workforce development or capacity dollars coming into the state of Indiana. How will we be able to leverage that may help us with our recommendations from this commission?
Paul, did you have? Oh, no, go ahead. That's fine.
I guess the answer to your question is no. There isn't a minimum number that's been established. In fact, there have been several research studies that have been started but never completed because there are too many contingencies to actually get to that number. Although there's currently one research project that's ongoing. They're struggling, but I don't think they're going to reach a meaningful number either because it's so dependent on the authorizing environment, and in this case, it's our state statutes, and they're so different in each county, each state, and so there are some states that have answered that question. So, for example, in Nebraska, they've decided that in order to be a local health department, I believe the statute says you have to be serving a minimum of 35,000 people. And so they've created a cutoff based upon the population served, and then they've come up with some minimum suggestions around staffing and so forth. But you have to first of all answer the question: so, what's the level of service that you have to provide? That's why I think the benefit of this foundational public health services, and Pam, I think you did a wonderful job in this presentation. I think it is increasingly the consensus of the field of public health that this foundational services of public health represents the model that everyone's moving towards. And Mr. Chairman, if I might, I serve actually on the Public Health Accreditation Board and this National Center for Public Health Innovation, where this model actually resides. And there is increasing interest in a number of the federal supplements that are being discussed right now around being able to help provide support for states and local health departments. And increasingly, there is a desire, I think, to move towards this kind of a model nationally. And I know Dr. Monroe could probably talk to you more about it, but one of the distressing pieces of news that we got from your web conference, Dr. Monroe, was some of the findings around the real workforce shortages that we have. Some 80,000 people that are estimated being needed to satisfy the workforce needs, and there are other estimates that are actually more dire than that. So, but almost everyone has moved towards this foundational services, which is also our recommendation in our report. If you look at, so if you look at the
It was in the
page
slides.
12.
Yeah.
There's a packeting. And then there's a paper that's actually on it.
Some of those aren't right, though. I noticed they're in the wrong categories. I don't know.
What, 12?
Oh, sorry.
No,
I thought
no, I was looking at this one here.
Yeah.
So anyway, the other quick thing to mention is that the Robert Wood Johnson Foundation has just recently released additional funding for this to expand collaborative work among states that are interested in doing the work like we're doing. And so I think that would be an excellent idea for us to consider applying for one of these grants, because they provide not only technical assistance, but a community of learning with other states that are interested in doing similar work.
I agree. I hope you all do. Indiana should definitely apply. Really timely.
While we're on that point, I noticed that in slide 8, you referred to look like 74 departments of being less than 50,000. And in other documentation that we received, I think the number that we were looking at was 65. And I think that's sort of a critical number when it comes to talking to the legislature, because they're the people who represent all these areas. So I'd kind of like to get some clarification.
We took ours out of the
between
Fairbanks
those.
School of Public Health report that they sent out. Is this based on a new census or anything? Where did you get this?
So this we got, what we got is from Fairbanks School of Public Health and your Indiana Public Health System Review, and then the map from ASTO.
So we can double check that number. We
Yeah,
can
I think it would be
absolutely
helpful
confirm.
to
Sure,
make sure that we have the right number there.
yeah.
Going forward. And then another point that I noticed, we talked about in Kentucky that the WIC program had been combined into the local health department program. Is that right? Is that a fair statement or is that incorrect?
No, the WIC program was considered one of their core public health
Okay.
programs or initiatives that they had defined as a foundational public health service.
Okay, so but that's a federal program.
Mhm.
It's run separately.
So
So we're not really talking about trying to combine with WIC. We may want to understand WIC better and have a better relationship, but it's not part of the combining exercise.
No, not
Okay.
not on that foundational level. You're
Okay.
exactly right. WIC is a federal program,
Yes.
but there will be programs embedded within, for example, at our Department of Health, we have a WIC division that is kind of the state hub or point of contact for that federal program and the local
Okay.
programs being administered.
Well, obviously, that's not my field of expertise, so, but it may be something that some of the members of the commission want to think about if that's something that needs to be
Mhm.
at least articulated in a report.
Sure.
Yes, sir.
I want to commend you on your report. This
Thank
is
you.
very, very good, and I hope we are able to make use of just about all of it. When it comes to the accreditation, so one of my counties is about 28,000.
Mhm.
We actually looked at the accreditation, and then COVID hit, so we didn't quite get across the finish line. It was a challenge of getting resources.
Yeah.
And I know that it'd be a challenge in several other counties, but the accreditation process does make you think, what am I doing? How am I doing it? I'm involved in other organizations for accreditation, like the Joint Commission and the American College of Surgeons. And when the American College of Surgeons goes into a hospital to accredit their surgery program, and they just look at themselves and do a good, deep self-evaluation, they come out better.
Yeah.
They find gaps. How do we fix those gaps? And I'm sure Mr. Tabor can talk about when accreditation groups go into hospitals.
Yeah.
Hospitals, they're forced to look at themselves, what are we doing? Are we doing it as best we can? And they come out better. And that's why those accreditation processes are there. So whatever we come up with, if we can at least encourage more to try the accreditation route so that they do a good self-assessment and they find out where their gaps are. And if they find gaps, they can let State Department of Health know, and that might help develop our regional resources.
Exactly.
differently. As we find out, like, we're trying our best, we can't do A and B, we can do C and D, we need some help there. And that might be something that they could say, well, have you talked to your neighboring counties? Have you talked within your Department of Health districts? So just some thoughts.
Exactly, and really agree with what you mentioned. It's really the accreditation process that really raises the level. And it does require you to examine processes, to make sure you have documentation, to make sure that you are hitting those benchmarks. And it's a rather rigorous process. But again, rising tide raises all ships. And at first, I mean, just from our team, what are we doing? But over and over, I heard, we should have been doing this anyway. Well, this was an opportunity for us because now we could take the time and say, well, we have to. And in the counties that are accredited, so Vanderburgh, Montgomery, and Rush, and that's a pretty good mix of counties. Rush being a very small rural one, they had some challenges. Now they have some, especially with staffing. But part of what they were doing was finding others to help out and then looking at other counties. So completely agree with you that I think there's a lot of benefit to that. And that's where our resource sharing at local level, but also training and resources from Department of Health can come into play, again, to bring everyone up to that standard.
I was just going to respond, if I could, to the accreditation
Sure.
comments. Three things, actually. One is that there will be a revision to the accreditation standards in this next year, and the revisions will in large part mirror the foundational services of public health. And there will actually be a way to actually test the degree of compliance with the foundational services. So that'll, I think, be really helpful, and it will create a greater alignment with a lot of the work that we're all doing. Secondly, there is now before the board a proposal to create what's going to be called a Pathways project. So there's a lot of, the vast majority of health departments in this country are small. And so there's common dilemmas around resource issues and so forth. And so to address that issue, there's going to be a process by which, working with NACHO, the County Health Officers Association, there will be a learning community that'll be created. It won't be an accreditation, but it will help small health departments get ready to be accredited, or at least be aware of the standards. So
That's great.
that will be there, and it's going to be at a very low cost. There's going to be the belief will be that there'll be federal government support along with some philanthropy support, so that this will be a very accessible service. So for small local health departments. And then third, there is going to be some relook at the fees for accreditation. So it will make it more obtainable for more health departments.
That's fantastic.
You know, Paul, I think where that question comes in as we kind of prepare a report and think about those things, and accreditation ought to be discussed. I think one thing for you in particular and others who have been involved in that process, and maybe Judy can help us here too, we need to be realistic about a time frame that you shoot for in terms of accreditation. If you took something to the General Assembly and it said we're going to start having accreditation occur next year, you might sink the bill right there.
Right. So Ohio, when they actually, I think it was mentioned that they actually require it, but they provided, I think it was a 3 to 5 year window.
About 4 years.
And
And support financially to do it.
Need to think how this ought to be structured.
Your point
That's
is
all
very
I'm trying
well
to say.
made.
But they did go from like 120 something now to 85 local health
Yes.
departments. So they've done some consolidation
Yeah.
even since I last reviewed it.
Yeah.
And what I would say is that not all of them are still accredited, but the point is they're making progress toward that.
Right.
They are instituting that.
Yeah.
Right.
And having been through this, now the State Department of Health has knowledge and abilities that we didn't have before, having recently got accredited ourselves.
I bet if Ohio can do it, we can.
I know we can.
Yes.
Just a couple of comments. It was good. It was good to read and hear the amount of collaborating or sharing already going on between counties. And, with 49, or not counties, but health departments, local health departments, with 49 reporting that they've done that. And I would say that probably the leadership in the counties where they reside don't even know of all that collaborating that's going on. So that's a very positive thing in my mind that it's happening. The other thing that I would like us to, I guess, think about or not forget, and I don't know how it all fits, but health care and public health really go hand in hand and can't be separated. And the physicians in the room certainly know that. My being in a hospital for 40 years, I understand a little bit of that as well, but it really does go hand in hand. And the government's role, in my mind, is not to overburden people with regulation and so on, but public health, in my mind, is one of the roles of good government. There's a lot of things that we can probably do away with, but public health is an area that's very important. And when you look at all the areas that affect people and their lives and so on, public health affects that. And healthcare is a quote part of that. So,
Absolutely.
yeah.
Absolutely. Thank you.
Pam, I have a question. A great presentation too.
Thank you.
Given the geography of the state, is it practical that we would see consolidation of the local health departments, or just expanding the sharing arrangements?
So, and then that might really come out of the recommendations of this commission, but what we heard in research and in talking with different local health departments, representatives, is really having that footprint in every county to some extent. We do have one institute of example rather of a shared health department, and predates me, I'll be honest. I would have to go back in the history and see what led to that. We have had instances where due to staffing, retirements, resignations, what have you, where a local health officer has stepped down, and we've had other, Dr. Welsh is an example, another local health officer will step in the interim to fill that gap, or there might be someone elected from a local health board that will step in and fill that gap in the interim. But what we heard was making sure, however way this goes, making sure that there is equitable access to those foundational public health services where they can be reached. So that zip code doesn't really determine you're not 2 hours away, but you've got local services being provided so that you don't have a long wait or you're not without. And that's what the foundational public health services framework really gets to, is making sure that we have those services established and that no one goes without. Now, that's the minimum, that's the floor, if you will. Now, as you move up from that and you get into some of the other services that maybe aren't as common, like TB investigation, for example, that might be where you partner with a neighboring county. Allen County, for example, does quite a bit of this, and other counties surrounding may not, so they may help out with that, or same thing with Marion County. So I think you can look at different shared resource models to cover the gaps in those services that are needed that maybe a smaller rural health department would not encounter every day. Or they might need a little bit more staffing help. So is that something that you can share an FTE nurse? Or is that something that the Department of Health looks at from a field team perspective? So there are lots of ways that you could do that, but it gets down to making sure that we have access to all local communities.
My last follow-up question to that is this: a few years ago, and I mentioned this before, we did a community needs assessment, and mental health and substance use treatment options were high on the list and continue to be the most least offered services in our community. Do you see public health integrating with those expansion of services?
Certainly it is. Opioid use disorder, mental health are becoming more and more in the public health realm. Our experience in those in traditional public health is not that long standing. Really, these have emerged to come into the forefront of public health pretty recently. What we did see before COVID, and really what the big issue facing public health before COVID was opioid use disorder and substance use disorder, and being able to provide addiction recovery services in communities. That may not come from a local health department, but it may come from a partner within the community. And then sometimes where you have issues of overlap, maybe in the naloxone provision or distribution, or sometimes we see communicable disease outbreaks that can result. That's where the local health department really can work in concert with those community providers of addiction recovery programming or mental health programming, but would ask Dr. Box or anyone else.
Well,
to weigh
I
in
would
on
say that if you even take a step further back from that, why do we have so much substance use disorder? And can we start addressing upstream
Right.
some of the traumatic things that have led to individuals reaching for things that harm themselves or harm other people. And so public health has a huge play in that area. And then our job, I believe, is making sure that our community has access to those services and advocating at the state level if there is not access to that. It's us going to FSSA, where Department of Mental Health and Addiction is, and saying, there is an issue here. There is no one treating pregnant women with substance use disorder. There is no one here that is actually doing treatment in the jail or doing treatment in other areas. So that's where I think public health is, on the upstream prevention side of that, but also in making sure that there's access to that care in their community.
That's a great point.
I want to thank Dr. Kane for her comments on the workforce.
Mhm.
So there was a report, I think NACCHO put out in 2011, and they had some ratios from a very old report in the 1940s, recommending 5,000 population to public health nurse. That was kind of reaffirmed more recently by the National Public Health Nurses Association. So I actually asked my team, accidentally, please calculate from 2019 what our population to public health nurse, meaning a nurse that reported they worked for a public health agency in the state of Indiana. And so our statewide average is 5,500 approximately people per public health nurse, so a nurse in public health agency. However, that is not distributed equally across our state. So I would, and to just also to Dr. Culberson's remarks, we really don't know for that comprehensive public health services what the workforce looks like, but what we do know is we do not have the workforce right now. We simply do not. Now, we have people in those professions potentially that are trained in the skills and the roles that can do that, but they're not working in the places where perhaps we need them. And so I do absolutely think that we need to be thinking through the workforce development strategies to come alongside the planning initiatives. That as we consider infrastructure, the reality is, I think I'm sorry, you said you have someone said they have one public health nurse, but they'd like one more, but you have 50,000 in your
66,000.
Okay, I'm sorry. So technically, right, you should have like 12, 13.
Yes.
See, I've been trying to help you out.
So, Hannah, so it also depends on what you're asking the nurses to do, right? So I know in some states, they do prenatal care, they do family planning, they do nurse visiting. So there's a whole variety of things that public health nurses would do. And so I think in the abstract, it's kind of hard to know what.
And
It is, and I only make this remark for us I do think it's important for us that we're considering infrastructure, we're considering, and even where is it appropriate to share?
No.
Some of
Absolutely.
that might actually be driven
Some people
by
might.
the workforce that we have in Indiana. And quite frankly, the way that we can afford to have that workforce right now. So I just wanted to make sure that that's.
And I hesitate to mention this a little bit, but in statute, a health department has to be run by a local health officer, which has to be a physician.
Yes.
And we have counties that struggle mightily with that. I had one county where the guy said, if I don't do it, my wife, who's a physician, is going to have to do it because we're the two people. And so realistically, there are health departments across the nation that are run by advanced practice nurses.
Right.
And run very well, and then could be overseen in a regional fashion by a potentially, masters in public health, even additional training, or for certainly individuals who have had additional education and support once they become a health officer, that we could work with somebody like the School of Public Health to do that. It doesn't even have to be the official title. The other thing I want to bring up, and I hesitate to do this, but I'm going to say this. In statute right now, cities can also become a local health department. And it happened throughout the pandemic. And I will tell you that what we have seen personally in the state of Indiana is that leads to very poor communication, collaboration, and partnership within that particular county, a division of resources. And I would strongly recommend that we have a lower limit of, and I wouldn't even say population size, but even no smaller institute than a county. That's a personal opinion, but I would throw that open to other people that have some knowledge about this.
We're
And
going to
that-
take care of that problem for you, Dr. Box.
You are?
Okay. And the other thing, I know Paul mentioned that a lot of public health nurses do family planning in public health. That is not the case in the state of Indiana. So I don't want you to be scared about the family planning of what public health nurses. Yes, right. But you shouldn't say that in the state of Indiana, okay? All right. So I can almost assure you, it must be 95 or 97% of public health departments do not do family planning in their health departments, okay? That may be, but we know what we've got to get accomplished through our state legislators and through this commission. So I want us to be realistic
Thank you.
and present a true perspective of what we're doing.
Ryan? Just on the workforce issue, while it's not specific to public health nursing, whether it's in the hospital setting, whether it's in the long-term care setting, it goes without saying that we're at a crisis level, unprecedented shortage, the demographics, the psychic and physical toll of the pandemic. We will be working on legislation, promoting legislation this session to work with some of our university partners to change some statutory limitations that are, I think, kind of unusual that Indiana has that I think have the effect of restricting pipeline. We're very excited about this. We've been challenged by our members to think big. I know it can be kind of a trite thing to say, you can't always keep doing things the way we've always done them. But there's some things about, I think, the way that we've really constrained that pipeline in Indiana that have to change. And while I get asked every day by my members, can you produce a busload of bedside nurses tomorrow? We can't do that. But honestly, I feel very good about some of our university partners and their ability to, with some help, I think, from the General Assembly, even in the short session. Now, even when we get to the budget session, well, I'm sure we'll have another phase of this plan. But I just really want to share that with the group. You may have heard about, some of these different concepts, but we're trying to work to build a coalition around it. And I realize I'm not asking the commission to endorse that, but I think since we have so many groups represented here, I just wanted to share it. And I'm hopeful that we can make some progress because I think it'll lift all boats. More nurses with a pathway from an ASN to a BSN on to APRNs and a public health specialty. It'll help improve our workforce for the future. So
Thank you, Brian. Well, very good presentation. Thank you very much. And very good discussion. I know you're all just getting your appetites whetted and you want to keep going, but it's 3:00. The head table here. Anybody have a final comment?
So I forgot to mention that on January the 26th, we've been blessed to have Dr. Welsh and Dr. Kane volunteer to lead our local health officers who will be invited from all across the state to join virtually and have a 2 to 3 hour discussion to make sure that we are hearing from the people that are on the front lines, that many of them have many, many years of experience, great knowledge and expertise in this area. And they will have a whole list of things that they would like to have covered, many of the things that we've talked about already here and we'll be talking about in the next 3 sessions. So very appreciative of the two health officers stepping up and being willing to do that. We're going to also send out to our administrators to ask the administrators to make sure that the local health officers have looked at their emails so that they see the invite there, because I know how that works. So thank you.
That's a great initiative. Judy, anything else?
I would just thank everyone and wish everyone happy holidays. I look forward to 2022. Somebody said the other day that we'll do it. We'll try again in 2022.
Susan, anything?
On behalf of the citizens of Indiana, thank you all very much and happy holidays.
Don't forget to take your paycheck.
Merry Christmas. Yeah.
let's really go over.
Yes, yes.